Shock. Shock is defined as a widespread abnormal cellular metabolism that occurs when gas exchange with oxygenation and tissue perfusion needs are not met sufficiently to maintain cell function. Shock is a condition, it's not a disease. It's basically the response of the entire body when too little oxygen is delivered to the tissues. When the body's compensatory mechanisms are not effective or they're used up, shock will progress and will lead to cell loss, multiple organ dysfunction syndrome, and death. There's four basic types of shock. We start off with hypovolemic. It is usually caused by a loss of total body fluid. For example, hemorrhage or diabetes insipidus, hemophilia, dehydration, etc. So we have a reduction in the intravascular volume of at least 15% or more. The venous blood that returns to the heart is now decreased because we don't have that volume, and the ventricular filling drops. The stroke volume, cardiac output, and blood pressure will all decrease. With cardiogenic shock, we have a direct pump failure. For example, from a myocardial infarction, cardiac arrest, cardiac tamponade, or ventricular dysrhythmias. And the heart pumping ability is now compromised. It's just not sufficient to provide adequate cardiac output or tissue perfusion. We have a definite reduction in MAP. The myocardium oxygen is progressively depleted. With obstructive shock, causes include cardiac function being decreased by a non-cardiac factor. For example, maybe we have cardiac tamponade, where the heart function is being manipulated because the pericardium is filled with fluid, for example. Or we have a pulmonary embolus, where the blood cannot get through. We have a tension pneumothorax, which is affecting the function of the heart, etc. We may see obstruction of the heart or great vessels, and it does impede venous return. Distributive shock, we have the normal amount of total fluid volume or even an increased amount, but because of a fluid shift from the vascular spaces or widespread vasodilation, we now have a larger space to fill, so we begin to see symptoms of hypovolemia even though we have a normal fluid volume. Specific causes may include a spinal cord injury or head trauma, anaphylaxis, sepsis, burns, pain, stress. So along with that widespread vasodilation, we also have a decreased peripheral resistance. Despite there being no change in the blood volume, again, hypovolemia will result. With septic shock, we know that sepsis will kill approximately 2,500 to 500,000 Americans every year, and septicemia will be the leading cause of death in the intensive care unit. We see both gram-positive and gram-negative bacteria. With anaphylactic shock, this is basically a widespread hypersensitive reaction or anaphylaxis with vasodilation. We may also see pooling of the blood peripherally in addition to the hypovolemia. With a neurogenic shock, we have an imbalance of parasympathetic and sympathetic stimulation of the vascular smooth muscle with vasodilation resulting. And then we have the blood pooling in the venous and capillary beds. We're going to see bradycardia occur, central venous pressure will drop, stroke volume will decrease as the MAP falls. In the early stages, the client will be warm and pink. As the shock progresses, the skin will become pale and cool. So there's different stages of shock that the body will go through, and there are 4 stages. The initial stage, we have the body compensating with vascular constriction and an increased heart rate. This will actually keep the cardiac output and the MAP within normal limits once those compensatory mechanisms kick in. And shock will be very difficult to detect at this stage. We will see initially a decrease in the mean arterial pressure, or the MAP, of 5 to 10 millimeters of mercury from the baseline value. We have increased sympathetic stimulation, mild vasoconstriction, and an increased heart rate. With the non-progressive stage, as stabilization and interventions are initiated, the client can remain in this stage for hours without permanent damage. If we stop the cause of shock and appropriate interventions are initiated, we can actually prevent shock from progressing at this point. The cardiovascular responses in the non-progressive stage that kicked in during the initial stage are no longer able to maintain the MAP and supply appropriate oxygen to the vital organs. So the kidney and hormonal compensatory mechanisms are now activated. So we start to see a decrease in the MAP of 10 to 15 millimeters of mercury from the baseline value. We also see continued sympathetic stimulation, moderate vasoconstriction, along with that increased heart rate, decreased pulse pressure, and chemical compensation with the hormones renin, aldosterone, and the antidiuretic hormone. These will all lead to water reabsorption. And then tissue hypoxia in the non-vital organs will occur. The client also experiences mild acidosis and mild hyperkalemia at this point. As we move into the progressive stage, the compensatory mechanisms are functioning, but they're no longer able to deliver sufficient oxygen even to those vital organs, and this now becomes a life-threatening emergency. However, the client's life can be saved if conditions causing the shock are corrected within 1 hour of symptom onset or less, but multiple symptom organ dysfunction syndrome and permanent damage can occur within a short time if no interventions are initiated. We begin to see a decrease in the MAP of greater than 20 millimeters of mercury from the baseline value. We have anoxia, or no oxygen, to the non-vital organs and hypoxia of those vital organs. Overall metabolism will be anaerobic at this point. We have moderate acidosis, moderate hyperkalemia, and tissue ischemia. And if we reach the refractory stage, interventions that we initiate will not save the client's life at this point. We have severe tissue hypoxia with ischemia and necrosis. We have a release of myocardial depressant factor from the pancreas. We have a buildup of toxic metabolites from the hypoxia. And as those cells begin to die, they release even more toxic metabolites. We begin to see multiple organ dysfunction syndrome, and finally, death. Risk factors for shock include an increased cardiac disease will increase that risk for cardiogenic shock. Individuals that indulge in high-risk behaviors such as driving under the influence or dangerous sports, they are at risk for trauma and shock resulting from bleeding or multisystem injury or a neurological injury such as the spinal cord or head trauma, or hemophilia. The onset of shock can be rapid or it can be slow, depending on the underlying cause and severity. So different symptoms that we begin to see are in the cardiovascular system, we have decreased cardiac output, the increased pulse rate, and that pulse becomes thready. That heart is increased because it's trying to get that blood perfused to all of the tissues. The blood pressure begins to decrease. We have that narrowed pulse pressure, postural hypotension due to that lowered blood pressure, a low central venous pressure, the flat neck and hand veins in the dependent position, especially with hypovolemia, slow capillary refill in the nail beds, and diminished peripheral pulses. With the respiratory system, we have an increased respiratory rate. The respirations are now shallow. Our PaCO2 begins to decrease along with the PaO2. We see cyanosis, especially around the lips and the nail beds. With the gastrointestinal system, this is a non-vital part of function to keep us alive. So the motility, that peristaltic action begins to decrease. And we may even have diminished or absent bowel sounds, along with nausea, vomiting, and or constipation. With neuromuscular, the early signs will be anxiety, restlessness, and increased thirst, especially if we have hypovolemia. With the late signs, we have the decreased central nervous system activity, where we begin to see lethargy all the way to coma. We also see generalized muscle weakness, diminished or absent deep tendon reflexes, and sluggish pupillary response to light. With the renal system, we have a decreased urine output. The reason for this, number one, if it's hypovolemia, could be due to the dehydration. But as the body goes through this shock state, it's trying to survive, so it's holding on to everything to try and keep itself alive, and that includes fluids. We have an increased specific gravity because we're not urinating, and sugar and acetone are now present in the urine. With the integumentary system, the skin is cool to cold, it's pale to mottled to cyanotic with coloration. It's moist and clammy. The mouth will be dry with a paste-like coating present, and we have a decreased capillary refill. The priority problem with hypovolemic shock and with any shock is going to be inadequate perfusion. With hypovolemia, it will be due to active fluid volume loss and hypotension. So what do we do to take care of these clients? Well, we need to elevate the feet initially to bring the blood to those vital organs. We need to keep the client warm and correct the cause of shock. They will require oxygen therapy either through a mask, hood, nasal cannula, endotracheal tube, or tracheostomy. And we need to maintain that saturation of at least 94 to 96%. If they have a normal SaO2 that may be above 96%, we don't need to administer oxygen unless it begins to fall. We also need to do fluid replacement therapy. We definitely need IVs with large bore cannulas for potential high volumes of fluid being replaced. We will usually use crystalloids such as normal saline or lactated ringers, or colloids if there was blood loss if we're replacing volume. And drug therapy will definitely be necessary. Some of the drugs we might use would be vasoconstrictors such as norepinephrine or phenylephrine. The inotropic agents such as dobutamine or milrinone, and agents that can enhance the myocardial perfusion such as sodium nitroprusside or nitroglycerin. We need to monitor the client at least every 15 minutes, and this would include the pulse. We need the rate, rhythm, and quality of the pulse, the blood pressure, the pulse pressure, the central venous pressure, the respiratory rate, the skin and mucosal color, oxygen saturation, cognition, and urinary output. Surgical management may be required to correct the cause of shock. With septic shock, beyond those interventions I just mentioned, within the first hour of symptom onset, we have to measure the lactate level, obtain blood cultures, administer broad-spectrum antibiotics in that order. These clients may also require insulin therapy and anticoagulation. Some of the diagnostic labs that may be necessary, we're going to get the arterial blood gases, a CBC, a metabolic panel, the lactic acid levels, and blood cultures. So this is the Modified Early Warning System, MUSE. We're going to be using this in just a minute as we look at our first case study. Jean Kelly is an 82-year-old woman who has been feeling more fatigued the last 3 days and has had a fever for the last 24 hours. She reports a painful burning sensation when she urinates, as well as the frequency of urination the last week. Her daughter became concerned and brought her to the emergency department when she did not know what day it was, as this was a new onset of confusion for Jean. Current vital signs: temp is 101.8 or 38.8 Celsius. Pulse is 110 regular. Respirations 24 regular. Blood pressure is 102/50. Oxygen saturation is 98% on room air. She has right flank continuous achy pain, a 5 out of 10. The daughter only recalls, excuse me, the last time that her mother urinated was last night about 19:30, and it's now 12 p.m. the next day. So what is Jean's MUSE score? Well, her temperature, that would be a 2. Her pulse would equal a 1. Her respirations would equal a 2. Her systolic blood pressure equals a 0. Level of consciousness with the new onset of confusion would be a 1. Urinary output, a 0. For a total of 9. So what do you anticipate occurring next? This client will require observation at least every 30 minutes and notification of the provider for orders, according to the MUSE table. So is this client at risk for shock? If so, what symptoms support this risk and what type of shock? Yes, she is at risk for shock. The symptoms that support this would be her age is over 80 years. She does have a probable infection, maybe a UTI. It could also be pyelonephritis leading to sepsis. She has a rapid respiratory rate, decrease to absent urine output, a change in her cognition, mild hypotension, an elevated temperature, and elevated heart rate. She could be experiencing or go into septic shock. We now have a client who's a 52-year-old male being treated for hypovolemic shock resulting from bleeding injuries received in a motor vehicle accident. He has a decrease in his MAP of 12 millimeters of mercury from his baseline reading, increased heart rate, decreased pulse pressure, decreased urine output, increased potassium level, and mild acidosis. He states, "I am so thirsty." In which stage of shock is this client? This client would be in the non-progressive stage. This occurs when the MAP decreases by 10 to 15. We have kidney and hormonal compensatory mechanisms activated because those cardiovascular responses are not enough to maintain the MAP and supply oxygen to the vital organs. We have decreased urine output. We have tissue hypoxia beginning to occur in those non-vital organs. And we start seeing the electrolyte changes, including hyperkalemia. So how does the body in shock cause the pulse pressure to narrow or decrease? Well, shock will cause that systolic blood pressure to drop, and that will cause a narrowing or decreasing of the pulse pressure. So the systolic pressure will decrease as shock progresses, and cardiac output will decrease. We have a reduced systolic pressure, narrowing the pulse pressure even further. When shock continues and interventions are not adequate, compensation will fail and both systolic and diastolic pressures will decrease. Okay, so what are the priority client problems for the client that are associated with hypovolemic shock? Well, we have hypoxia and impaired tissue perfusion. And finally, as shock progresses, what members of the interprofessional team should be consulted to address care coordination and transition management? That would be chaplain services, social services, and case management. As shock progresses, the client and his family may need to visit with the chaplain to address spiritual needs. Social services may need to be contacted to discuss options. And of course, the case manager would oversee the entire case. So the client has decreased oxygenation and impaired tissue perfusion. Which clinical manifestations are evidence of onset of the non-progressive or compensatory stages of shock? Select all that apply. We have decreased urine output, low-grade fever, narrowing pulse pressure, decreased heart rate, increased sodium reabsorption. The correct answers: A, C, E, and F. Which client is at risk for obstructive shock? The client with the history of angina, the client with chronic atrial fibrillation, the client with a pulmonary embolus, or the client with a history of heart failure. The only one that would cause obstruction would be C, pulmonary embolus. And finally, the nurse is performing a morning shift assessment on several clients. For which client is the nurse immediately concerned about decreased tissue perfusion if the cap refill time was delayed? The client with diabetes mellitus, the anemic client, the client with peripheral vascular disease, or the client with severe dehydration? The correct answer is D, the client with severe dehydration. They already have decreased fluid volume, so they are going to be at a higher risk for shock.